Hello, hello. This is the continuation of the newborn complications lecture. I'm now going to talk about LGA infants. So the LGA infant, that is large for gestational age. The causes can be from diabetes or from obese moms. Now, we can consider LGA infants to be greater than 4,000 grams, and you can easily mistake large preterm for term, so look for other physical signs of maturity. Therapeutic management of the LGA infant includes assessing for birth injuries, particularly the broken clavicle. These babies obviously have difficulty in traversing the vaginal canal, and because of their size, they are more likely to have a broken clavicle. They may also have hypoglycemia, brachial plexus issue, again, because of their size, a cephalohematoma due to their large head with trauma on the delivery from forceps or vacuum, trying to get them out to be born. And because of that, they may also have jaundice. So nursing considerations for that LGA infant are to assess for injury, feel for crepitus, feel those clavicles for crepitus, for asymmetry, pain on movement, make sure that they are moving both extremities, and that they are not keeping their one arm still, which would be an indication of potentially a fractured clavicle. I'd like to move on to high-risk newborn birth-related stressors. So this is slide number 27, respiratory complications, starting with asphyxia. Obviously, the first issue that we have to deal with when there are complications with a birth is breathing, airway. And so let's talk about asphyxia. And that is a lack of O2 and excess CO2. All organs are at risk. So this can be due to drug use, placental insufficiency, cord compression, or respiratory acidosis. So with asphyxia, there is the potential that it is because of primary or secondary apnea. So primary apnea is the baby is not breathing at birth, but that's easily established with stimulation. And as I had spoken earlier today, primary apnea is what you would see in the NICU for that baby who has stopped breathing. You flick their feet, you say, baby, baby, wake up, and they automatically start breathing again. That is primary apnea. Secondary apnea is much different. Secondary takes more of an effort with intubation to establish breathing. Secondary may occur at birth with primary that occurred while still in utero. So that's really important to understand. Secondary apnea, you cannot just stimulate their foot, stimulate them with sound, with verbal cues. To get them to breathe, you have to intubate or establish continuous positive airway pressure with bag and mask resuscitation in order to get these babies to breathe again. Let's move on to transient tachypnea of the newborn. Okay, so this occurs because amniotic fluid is in the lungs. And this occurs most frequently with that C-section infant who did not have the vaginal squeeze to remove that additional amniotic fluid from their lungs. So TTN is due to amniotic fluid accumulation in their lungs that has not been squeezed out, and it's the most common reason for a NICU admission. These babies grunt, flare, retract. There may be cyanosis. They may have cyanotic gums. And we typically do not PO feed them due to the potential for aspiration. And because they are tachypnic, as I had mentioned in previous lectures, babies who are tachypnic, which is a respiratory rate greater than 60 breaths per minute, we do not attempt to feed babies who are breathing at 60 breaths per minute. So no PO feeds are given. We can place an NG tube feeding, an NG tube. We can give them IVs, and we can give them antibiotics for sepsis if that's an indication. Because tachypnea can be a sign of sepsis, Often these babies are covered until we get the 72-hour cultures back. Probiotics are a good idea in this case. Next, I'll move on to meconium aspiration syndrome. So meconium aspiration syndrome occurs in 10 to 15% of all births. This is when the infant, actually the fetus, passes stool in the amniotic fluid. And so, as I had mentioned before, that fetus, when they are in utero, they are making breathing movements, and they are inhaling, so you would say, inhaling amniotic fluid, and that's how the lungs mature. If that is stained with meconium, that then becomes entangled in their lungs, okay? And so that's meconium aspiration syndrome, when that fetus inhales meconium in the amniotic fluid, inhales it into their lungs. That can cause sepsis, it can cause severe respiratory distress, and that is why we always suction mouth first and then the nose, so that they won't aspirate fluid before their first breath. If there is meconium at delivery, and when the membranes are ruptured, the healthcare professional, even the nurse, can determine whether it's meconium staining. You would look for yellowish brown or even black meconium in the amniotic fluid, and then the NICU should be contacted, because a neonatologist or neonatal nurse practitioner should be at that delivery to determine whether thick mech is below the cords, and that requires an intubation to look below the cords to see if meconium has been aspirated, in which case the baby would need to go to the NICU. And that baby would be observed for sepsis as well. Persistent pulmonary hypertension of the newborn, that is when the vascular resistance should go down but doesn't. Lung development is abnormal. This baby could have sepsis, polycythemia, diaphragmatic hernia, or tachypnea. We give surfactant, we assess the pulse ox, that perhaps that baby may need nasal prong CPAP as well. And this is because the vascular resistance should go down, but it doesn't. That's persistent pulmonary hypertension. Hyperbilirubinemia. That is, we're going to talk about pathologic jaundice. Pathologic jaundice occurs when the level of jaundice is between, it starts at 5 to 7 milligrams per deciliter, and that's the bili level in the first 24 hours, and that is abnormal. Remember, elevated bilirubins within the first 24 hours is considered pathologic jaundice, and it is abnormal. So the causes are unconjugated, unbound bilirubin in the bloodstream. It may stain the brainstem tissue, and that is called kernicterus, and that is an emergent situation as bilirubin crosses the blood-brain barrier. The mortality can be as high as 50%, and these babies, if they do survive, can have cerebral palsy or a significant intellectual deficit. And so that's why we don't want this bilirubin to rise to dramatic levels. To mid-20s to 30, that's considered a dramatic level that could be a potential for kernicterus. So we treat elevated bilirubins, and we take them very seriously. Blood RH or ABO incompatibility with mom can cause isoimmunization, and that can cause these elevated bilirubin levels. Erythroblastosis fetalis and hydrops fetalis, that causes severe anemia. Again, this is caused by this isoimmunization. Mom who is RH sensitized, or there's ABO incompatibility, can cause isoimmunization, and we can have a baby who is severely anemic. That's what this hydrops fetalis is, because the baby's blood their red blood cells have been hemolyzed, causing severe anemia in utero. This is most commonly with the RH system. It is incredibly rare in the ABO incompatibility blood system. Next would be, and of course, RhoGAM would prevent this from occurring. And so that's why we are very cautious with moms who are Rh negative, and we administer RhoGAM as indicated to prevent this erythroblastosis fetalis, meaning their red blood cells are destroyed through hemolysis, causing severe anemia in that fetus, and the baby can be actually a stillbirth. Therapeutic management, as I'd mentioned, you prevent with RhoGAM. You may need to exchange transfuse, and actually that's a current treatment. If it is discovered that mom has been Rh sensitized, we can do an exchange transfusion through the umbilical artery and vein, take 10 ml out, add 10 ml, and take out antibodies and unconjugated bilirubin. The baby has a total blood volume level of about 200 ml. We will also provide phototherapy, and typically it's double phototherapy. It's phototherapy with the blanket as well as phototherapy with spotlights. Typically, it gets worse before it gets better. Water loss with the light and heat in the isolette may rebound back, and there's pictures in the book to show you that, and that's on page 641. Infection. So infants are prone to infection. Preterm infants are prone to infection, and the transmission of infections, they can be exposed before, during, or after birth. Most commonly of these 4 would be GBS, Group B strep, and that's why typically we screen pregnant women in their last trimester for Group B strep. We do Group B strep cultures, but they could also become infected with rubella, CMV, or syphilis. So sepsis neonatorum, the cause is undetected maternal infection. We didn't know that mom was infected, and the baby is born and the baby is severely infected. So if the baby is delivered without prophylaxis, meaning mom was not treated with any antibiotics prior to delivery, then the baby is worked up for an infection. So symptoms of sepsis in a baby are bradycardic episodes, apneic episodes, cyanosis, metabolic acidosis. Always suspect that umbilical line if this is a premature infant that has required umbilical line entry for medication or for infusion purposes. The therapeutic management for sepsis neonatorum includes drawing a CBC, blood cultures, obtaining a lumbar puncture. As I demonstrated earlier today, you would lay the infant supine, actually roll them on their side, put them in a C position so that the spinal column is elongated, and the neonatologist or neonatal nurse practitioner can locate the appropriate entry for the lumbar puncture. We watch for symptoms of temp instability during this process, and we will then administer antibiotics to this infant. And typically, if they are infected, they will receive at least a 7-day course of probably ampicillin and gentamicin. Nursing considerations, 2 doses of antibiotics to stop transmission to baby before birth can be given, okay, and that's what this term prophylaxis, mom was pre-treated. That's with prophylactic antibiotics to prevent the transmission of infection to the infant. Nursing interventions, of course, would include good hand washing and provide antibiotics for that infected infant, and teaching the family as well and being very supportive. Okay, so here is an opportunity for you to calculate medications. So again, as I mentioned, typically we do include medication calculations in our maternity exams. So this is an opportunity for you to practice. A 2150 gram infant delivered after a range of motion for rupture of membranes times 36 hours, demonstrates temperature instability, is hypotonic, and has a weak cry and poor color. Okay, so these are the signs of an infected infant. Okay, and classic is that rupture of membranes for 36 hours. We'd like to have that infant delivered within 24 hours of rupture membrane to prevent sepsis. And so this infant obviously is demonstrating temp instability, hypotonic, weak cry, poor color, classic signs of sepsis. So rule out sepsis is the diagnosis. We have orders that include ampicillin, 100 milligrams per kilo IV Q12, and gentamicin, 4 milligrams per kilogram IV Q12. What are the correct doses of antibiotics? And so please take a minute and do those calculations. I think it's very important that you practice these calculations so that you're able to do them quickly during an exam situation. So the correct answer, okay, is 2.15 kilograms times 100 milligrams for the ampicillin becomes 215 milligrams IV Q12. So that was a pretty straightforward one. And then we have the gentamicin at 4 milligrams per kilo IV Q24 becomes 2.15 times 4 equals 8.6 milligrams IV Q24. And it's very important that gentamicin levels be obtained at the third dose, and that would be a peak and a trough level. And we would follow those levels to make sure that it is a therapeutic dose and not a toxic dose. Let's move on to the infant of a diabetic mother. The infant of a diabetic mother, the scope of the problem is dependent on glucose control in pregnancy. And these babies have 5 times the infant mortality above a non-diabetic mom. So characteristics of these babies are large for gestational age. Because they've had such a high infusion of sugar, they are fat. They are big fat babies. They can be 10, 12 pounds, these infants of a diabetic mother. The length may be appropriate. They typically have poor muscle tone. They're irritable. They have tremors because they become hypoglycemic very quickly. Glucose levels less than 40 to 45 depends on hospital protocol. Their liver, lungs, and kidneys have accommodated in utero and may be slow to respond after birth. Therapeutic management, expectant injury. Because these are very large babies, again, we will look for crepitus on the clavicle because this could be potentially a difficult delivery. Nursing considerations, these babies require frequent blood sugars. Why would that occur? Because this baby has been receiving constant high doses of glucose if mom has not been in control. If she's been running glucoses in the upper 200s, 300s, 400s, this baby is getting high doses of glucose, is making them very fat, but it's also the baby is creating the insulin to break down that glucose. Once that baby is born and the cord is cut, the glucose then is cut off. That high infusion of glucose is cut off, but the baby's system does not realize that. And so the baby's system is continuously creating this insulin. And so we have a rebound hypoglycemic effect. So these babies are prone to hypoglycemia. And so they need to go to the ICN. They get frequent blood sugars, and that's before the first 3 feedings. They are fed formula to replace the glucose. They're not fed water, and we use D10 via IV if hypoglycemia persists. Nursing interventions are early detection and monitoring. The best nursing intervention would be to educate this mom in glucose regulation so that she maintains her glucose within very set parameters and doesn't have significant hyperglycemic episodes. But beyond that, for the baby, we want early detection and monitoring, breastfeed, and then supplement. Polycythemia is common, so is hyperbilirubinemia with these babies. We may also detect RDS early along with birth trauma for these babies because they are large, and they may be born earlier. They may be born at 37 weeks just because of their size. Polycythemia. Polycythemia. The causes of polycythemia in utero: more blood cells than normal, and that's a response by the liver to hyperglycemia in effort to use extra glucose. So these babies have hemoglobins of 22%, hematocrits greater than 65%. That is polycythemia. Hemoglobin of 22%, polycythemic. These babies are red and ruddy. They're lethargic. They have an exaggerated startle, so that means that their startle reflex is exaggerated. They do it for a long time. And they have a poor suck. Therapeutic management: Billy lights. Because of this high hemoglobin and hematocrit, there is the potential for a lot of RBC breakdown, and so they are prone to hyperbilirubinemia. They may also need a transfusion, partial or full exchange, depending on the severity of the polycythemia. Be very careful with a heel stick. It's very difficult to get blood out of these babies, and they bruise easily. So definitely they would be a candidate for a heel warmer prior to any blood being drawn. Nursing considerations: assess early for jaundice, establish feedings which can be lengthy and baby tires easily, monitor their output. Hypocalcemia. Hypocalcemia. The causes are early onset, and these are in infants of a diabetic mother, asphyxia, prematurity, mom on anticonvulsants, or delayed nutrition. Late onset can be caused by hyperparathyroidism, malabsorption, low magnesium levels, diuretic therapy, and rickets. The manifestations: these babies, they are irritable, they are jittery, they are poor feeders. And you look at irritability, jitteriness, poor feeding, you think hypoglycemia. But no, if you take their glucose level, their glucose is normal. So you then immediately think of hypocalcemia. So they may also have a high-pitched cry, they have muscle twitching, they are prone to apnea and seizures. They may also have ECG changes. So sometimes it may be asymptomatic, meaning they have no symptoms at all. If glucose is normal, again, calcium level is then drawn, and they are hypocalcemic if their level is less than 7 milligrams per deciliter. So the therapeutic management is cardiac monitoring. Obviously, they may need a PIC or a central line is preferred. Be alert for bradycardia and dysrhythmias. Listen for bowel sounds. Nursing considerations: assess feeding and prevent tiring and overstimulation. They need a dark, quiet environment and cluster care. If they are asymptomatic, we will provide them with 80 milligrams per kilo per day of 10% calcium gluconate for 48 hours, as per doctor or nurse practitioner's order. And then 8 ml per kilo, which is equivalent to 8 ml per kilo per day of 10% calcium. Then we taper to 40 milligrams per kilo per day for 24 hours, and then we discontinue the infusion. If they are symptomatic, that is for the asymptomatic baby. For the symptomatic baby, we will give them a bolus of 2 ml per kilo of calcium gluconate diluted 1-to-1 with D5 and W over 10 minutes. And this is under continuous cardiac monitoring. And then we follow that by 80 milligrams per kilo per day for 48 hours and document normal calcium levels, and then taper as above. You have to be very, very careful with calcium infusions. They should be administered very slowly, stopped immediately if bradycardia or a dysrhythmia occurs. The IV site, if it is not a central line, you need to watch it constantly and assess it, because if it infiltrates, you can have a severe slough necrosis, and that's why that central line or PICC line is preferred to infuse calcium. And that's with any patient that you're taking care of. If there's calcium going through that line, that should be a central line and not a peripheral one, because of the slough necrosis that occurs if the IV becomes infiltrated. Prenatal drug exposure, the infant of a substance abusing mother, also known as ISAM, infant of substance abusing mother. So how do we identify these moms? Okay, we identify them by drug screen. Okay, we may test the meconium, the urine, the umbilical cord blood of the baby for opiates, and this also could be tested for cocaine, methadone, amphetamines, benzodiazepine, antidepressants. They all cross that placental barrier. It develops in 55 to 94% of drug-exposed infants, okay? These babies can be very difficult to manage, and it's just a very sad and challenging issue for nurses to face. So symptoms depend on the drug used, the amount, how the mom's body broke down the drug, mom's last use, and the baby's gestational age. So there are a lot of factors that come into play, and so there's no true recipe to treat these babies. We have to look at the symptoms, we have to look at what mom was doing and when, and look at the baby's gestational age. So symptoms may begin 1 to 3 days or even 10 days after birth. The physical characteristics you'll see on a subsequent slide. FAS is on slide 33, but some have significant physical characteristics. Therapeutic management, we score these babies with an NAS score, and there is a specific criteria. We will score them for tachypnea, for sneezing, for jitteriness, for sweating, for regurgitation, for not tolerating feedings, for water loss, diarrhea, for being asleep only 1 hour in between feedings. All of these criteria receive scores of 1 to 3 depending on the severity. Then we add these up and we come up with their NAS score. And so 3 times, if it's greater than 8, or 2 averaging greater than 12, we will treat these babies. We'll treat them with morphine, 1 milligram per kilo per day. We will monitor them. This baby needs to stay. Some of these babies stay weeks. Some of them have stayed longer than a month, depending on the severity of their substance withdrawal. We decrease the meds according to their scores. We continue to score them Q4 hours, and we gradually wean the morphine until they're finally off the morphine and can tolerate feeds and are gaining weight. The baby will be in the NICU or in a transitional nursery for this process. And you can imagine how difficult this is for nursing staff to work with this mother, and we have to be very cognizant to treat her in a non-judgmental way so that she will come back to the nursery and she'll want to be interested in her baby. And we have to become very involved with social work, who will speak with mom, who will perhaps do a home assessment, a family assessment, and determine what is the best situation for this baby. Is grandmom or an aunt or a close friend available to take responsibility for this baby while mom goes through perhaps a detox situation, or she gets help herself until she is able to care for this baby? So a lot of things to consider for that social worker. And unfortunately, we see a lot of these babies going through withdrawal. Prenatal drug exposure, nursing considerations. The NAS score is done for the presence and severity of symptoms starting 2 hours after birth and every 4 hours. These babies are typically very poor feeders. We may end up using a higher calorie formula. And classic newborn formula is 20 calories per ounce. They do make formulas at 22 and 24 calories for babies with special needs. And in this case, if a baby's not eating well, if we're able to get them to eat perhaps 15 or 20 ml of a 24 calorie formula, certainly that would be better for them to gain weight than utilizing a 20 calorie formula instead. Breast milk can reduce the need for treatment, but we have to be certain that mom is not using any more. Rest. These babies need a lot of rest. We hold the baby away from your face, and we teach mom to be quiet with the baby, bundle tightly. Typically, we keep the nursery dark, low stimulation, and gentle vertical rocking. And so we would hold the baby upright, but away from your face, and teach mom to be quiet in holding the baby. It's very challenging because these babies typically are crying, chronic criers. And so as you can imagine, if mom is a drug abuser, the thought of sending a very irritable baby home to a mom who is using or has the potential to use is a very, very difficult undertaking. And so we really need to establish the fact that mom wants to take this baby home, that she stops using, that she is willing to go through rehabilitation process and has support people that are willing to assist her in caring for her baby during that process. So bonding. Baby is often crying and very irritable, and so we have to show mom how to hold the baby away from your face, teach mom to be quiet with the baby, bundle tightly, very snug, and limit stimulation. So we need to avoid judgment again, and this can also be a challenge when grandparents are visiting and they may want to know why the baby is staying longer than what he should be. And it is not our place to inform grandparents that the baby's staying because of drug exposure. That's the responsibility of the parent. Okay, so we cannot say anything. We are bound by HIPAA to not inform grandparents regarding any of the issues that are taking place with their grandchild. So fetal alcohol spectrum disorder is the leading cause of potentially preventable intellectual impairment. So these are some pictures that I had mentioned earlier regarding fetal alcohol syndrome. So you can see the similarities in all of these faces. Look that they have an indistinct philtrum. The philtrum is this space in between the nose and the mouth where typically you have two ridges. That's the philtrum. They are missing a philtrum. They don't have a philtrum. And all fetal alcohol syndrome babies have faces like that. They typically have very thin lips. You can see this very thin upper lip, a flat mid-face, short nose, small head circumference, small eye openings, thin upper lip, low nasal bridge. So this is the classic picture of a fetal alcohol syndrome baby. Moving on to inborn errors of metabolism. Inborn errors of metabolism, the causes are genetic disorder where the body can't turn food into energy. And so there could potentially be a developmental delay with altered central nervous system symptoms. Manifestations are the breakdown products found in the blood. So therapeutic management, many different diets for each type of error. So nursing considerations, they may have feeding problems. They may need a specific designer formula made by Children's Hospital of Philadelphia, made by a special pharmacy that's specific to their need for their genetic disorder. And so the options are fructose intolerance, galactosemia, there's maple syrup urine disease, there's phenylketonuria. There are more than 50 inborn errors of metabolism that can cause varying degrees of altered CNS symptoms, and these babies all require specific formula tailored to their specific disorder. Blood tested at least 24 hours after the first protein intake, okay, so that we can detect this inborn error of metabolism. You can also test CSF if symptoms are present. Symptoms can start just days after birth. And this is so important because, you know, a child who has phenylketonuria, if they ingest food that contains phenylketones, then they can have intellectual delays. And so it's so important that these things are diagnosed early. That's why we test all newborns just after 24 hours of life when they've consumed protein to see if they have any of these potential inborn errors of metabolism. Congenital heart defects. So I know that you've probably had a lecture regarding congenital heart defects in pediatrics, but I'm just going to go over a few of them. So we typically talk about congenital heart defects as the acyanotic defects and the cyanotic defects, and that's very clear to see when assessing a baby. The acyanotic defects are the babies are pink, okay? They're not blue. Okay, so this, you may hear the PDA, which sounds like a washing machine, but the baby is not blue. And then we have the cyanotic defects. That baby is blue or dusky, okay? And there is blood flow decreased to the lung, and this could be transposition of the great vessels. There's left to right shunting. That could be the patent foramen ovale, higher pressure on the left side, VSD. Defects with obstruction of blood flow. This is pulmonary stenosis or coarctation of the aorta. There's also defects with decreased pulmonary blood flow, and that's tetralogy of Fallot on the right side of the heart to lung problem. You may have circumoral cyanosis and gums are blue. Pressure on the right arm is normal, and then below that PDA, the other three extremities have low pressure. There are great pictures in the text. Here you can see them. So this is just to become familiar with. You don't have to go through and know all of these defects and the treatment for the baby. You just need to be familiar that they exist. So the manifestations of babies with congenital cardiac defects. If feeding, they will become fatigued easily. They have a weak suck, and they just become so exhausted, they often require gavage feedings as well. And sometimes we'll just place an NG and try to PO feed them Q3 hours. And what they don't consume because of their recommended total fluid limit, we will give them the remainder through their NG tube. These babies may have cyanosis, heart murmurs, tachycardia, and tachypnea. So we provide small feedings, small frequent feedings. They also have poor weight gain because they're using all their energy to circulate, and so very little energy is left for growth. All their energy is used for their basic metabolic functions, for their heart to pump and to breathe. Therapeutic management depends on the defect. They could have surgical correction. They could be on DIG. They could be on diuretics, potassium supplements, and O2, depending on the severity and type of defect. Nursing considerations, we may want the PDA open to have blood circulating, depending on the defect, and give prostaglandins. We check color, rest, gavage feeds. higher calories, not 20 calories per ounce. Again, these babies are candidates for a 22 or 24 ounce formula because they are unable to consume a fair amount of volume or an appropriate volume for their size. We increase the caloric content of the formula so that they're able to consume enough calories to have some growth. These parents need a lot of support. They are devastated because their child's not perfect. Not only is their child not perfect, but they have a significant congenital cardiac defect. Okay, critical congenital heart disease. This is a wonderful program that nurseries have taken on probably within the past 5 years, and it is critical congenital heart disease screening. And we can do this using pulse oximetry. It's a very simple screening tool that we use on all newborns prior to allowing them to go home, prior to discharge. So it's only a 2 to 3 minute screening process, and we're making sure that we are not sending home a baby that we've missed a diagnosis for a critical congenital heart defect, because if a baby's been being discharged at 48 hours of life, as you know, perhaps this diagnosis was not evident. And so with this pulse ox screening, we can detect that. So congenital heart disease is the most common birth defect, accounts for 40% of death, 40% of the deaths from congenital anomalies. 3 out of every 1,000 babies are born with a severe form of congenital heart disease or critical congenital heart disease, CCHD. And it's estimated that 2,000 will have a misdiagnosis or die. 2,000 babies. So nurses can help prevent complications from missing the diagnosis of critical congenital heart disease by spending only a few minutes to screen newborns using pulse oximetry at 24 hours after birth. And so it's important that you can click on that and see how that protocol works. But I'll review this screening tool. So you put the pulse ox on the right hand and on one foot after 24 hours of age. And so the pulse ox should read greater than 95% or equal than 95% on the right hand or foot. And there should not be a difference of less than 3% between the right hand and the foot. And that is a pass. So you want a 95% reading for that, right hand and foot. And they pass and go on to newborn care. Okay? If they are less than 95%, both right hand and foot, and the difference is greater than 3% between the right hand and foot, they fail. And we need to repeat the pulse ox in 1 hour. If again they fail, we repeat it in the pulse ox again in 1 hour. And if they fail again, then we do a clinical assessment and call cardiology. It's very important that cardiology be notified and they can determine what the next step is for this baby. Okay, so these are the congenital heart defects that we can rule out. We can either discover them or we can rule them out that the baby is, we can safely say the baby does not have this using the pulse ox screening after 24 hours. So these are really significant congenital heart defects: coarctation of the aorta, hypoplastic left heart, truncus arteriosus, single ventricles, pulmonary atresia, tetralogy, tricuspid atresia. Okay, so these are all can be discovered with a pulse ox used after 24 hours and prevent that crisis at home of a baby dying. Okay, so this is the completion of neonatal complications lecture from this morning. Please, if you have any questions, feel free to email me, and I'd be happy to review any of this information in subsequent lectures that I have. Thanks so much.